Welcome to Chiropractic Science, where you get to hear interviews with leading chiropractic researchers from around the world. Hear about chiropractic research from the authors in plain English, not through the media nor a middleman. My name is Dr. Dean Smith, and I am the host of Chiropractic Science. I'm an associate clinical professor in the Department of Kinesiology and Health at Miami University, and I'm also a chiropractor in Eaton, Ohio. My research interests relate to understanding how chiropractic affects motor control and human performance. Today I have the privilege of interviewing Dr. J. David Cassidy. But before we get to the interview, I wanted to thank all of you who have subscribed to Chiropractic Science, and I'm especially appreciative to all of you who have contributed 5-star reviews on iTunes. iTunes really helps others find out about chiropractic science, so if you like the show, please take a second and write a review. It will support chiropractors everywhere. I'd like to share a review by Brooke Craven, who says, "Awesome podcast. Dean, host of Chiropractic Science podcast, highlights all aspects of chiropractic health, science, and more in this can't-miss podcast. The host and expert guests offer insightful advice and information that is helpful to anyone that listens." Well, thank you for that review, Brooke. I look forward to sharing your flattering iTunes review in a future podcast. Please consider making a contribution to Chiropractic Science to keep these podcasts going. You could do so on our website either by making a donation or by purchasing the evidence-based patient education slides presentation at chiropracticscience.com. We are also on social media, including Facebook and Instagram, so please connect with us there. All right, on to the podcast. Well, let's get on to the interview with Dr. J. David Cassidy. Dr. Cassidy is a professor of epidemiology and health policy at the Dalla Lana School of Public Health at the University of Toronto. He is also an Adjunct Globalization Professor at the Faculty of Health at the University of Southern Denmark. He began his career as a chiropractor and later obtained graduate degrees in surgery, pathology, and injury epidemiology. His past appointments include Assistant Professor of Surgery and Rehabilitation Medicine at the University of Saskatchewan, Associate Professor of Public Health and Medicine at the University of Alberta, Senior Scientist at the Toronto Western Hospital Research Institute, and Professor of Sports Science and Clinical Biomechanics at the University of Southern Denmark. His research focus is injury epidemiology, neurotrauma, musculoskeletal disorders, and evidence-based healthcare and policy. He has published over 300 articles and chapters in textbooks over his career, including papers in the New England Journal of Medicine, the British Medical Journal, and Annals of Internal Medicine, JAMA Psychiatry, and the Archives of Physical Medicine and Rehabilitation, to name just a few. He is particularly interested in the psychosocial determinants of injury, recovery, and long-term consequences of injury. He also serves as a coxswain in the Royal Canadian Marine Search and Rescue on Canada's West Coast. Dr. Cassidy, I've wanted to have you on the podcast for such a long time, and I'm super excited to have you on the Chiropractic Science podcast today. So thanks for coming on.
Well, thank you very much for hosting me.
Absolutely. Well, I'm excited to dive in and hear about all the neat things that you've been up to in your career. I've read a ton of your articles, and I'm just really excited to talk about them. So first, though, probably the majority of listeners are chiropractors. Can you tell us how you became interested in becoming a chiropractor in the first place?
Yeah, sure. Of course, that was many years ago. And at the time, I was a student at the University of Toronto, and I had plans to go into plant physiology. And I started to realize that jobs in the area of plant physiology at that time were hard to come by. And I happened to meet a chiropractor, David Drum, who at the time was the chiropractor for the National Ballet of Canada. And I just found him to be very interesting, and he had a beautiful office in downtown Toronto, which I visited. And he had written a book about biomechanics, which he gave to me, and I read that and became quite interested in it, in the profession of chiropractic. So I applied to CMCC and was accepted, and that's how I became a chiropractor.
That's terrific. So, can you take us up through what your career has been like over the last, let's say, 20 or 30 years since after you graduated chiropractic school? I know you went out west in Canada to start in on research, and I believe also practice as a chiropractor for some period of time. Can you tell us about those earlier experiences?
Yeah, sure. I graduated from the Canadian Memorial Chiropractic College in 1975 and practiced for a short time in Toronto. I didn't have my own practice. I practiced with a more experienced chiropractor. And then an opportunity came up to take a job in Saskatoon, Saskatchewan, which is on the prairies in Canada. It was a combination clinical practice academic job to work with the then professor of orthopedics at the University of Saskatchewan, William Kirkcaldy-Willis. And KW, as we called him at the back then, he was a Scottish missionary surgeon from Africa that had immigrated to Canada and had become the head of orthopedic surgery at the University of Saskatchewan Medical School, and had become fairly famous as a person involved in the treatment of spinal stenosis and other back problems. In fact, I think he was one of the first surgeons to fuse spines for tuberculous lesions, and he did most of that work in Africa. And he was building up academic department at the University of Saskatchewan at the Royal University Hospital in Saskatoon. And he had worked with an osteopath chiropractor in Africa and wanted to bring a chiropractor into his back pain service at the Royal University Hospital in the Department of Orthopedic Surgery there. And so he approached the chiropractic college and asked if there was a young chiropractor that would be interested in moving to Saskatoon and working with him at the university there. And I applied for that job and was accepted and went out to Saskatoon. And I basically worked as a chiropractor at the low back pain clinic at the University of Saskatchewan with Kirkcaldy-Willis, and also had worked in an outpatient chiropractic clinic in Saskatoon. And I did that for a number of years, until about 1997. And after that, I went into full-time, became a full-time academic or a university professor. And during between 76 and 97, I practiced as a chiropractor, ran a chiropractic residency program in conjunction with the Canadian Memorial Chiropractic College at the Royal University Hospital. And basically that was a program that chiropractors from CMCC, chiropractic residents or postgraduate trainees, participated in. And they came to Saskatoon and would do 6-month rotations through the hospital, attending back pain clinic, rheumatology clinic, neurology clinic, pain management clinic. So there was a specialized residency for chiropractors, and it was a very successful program. I think we put through probably around 50 or 60 chiropractic residents. And my role during that time was to participate in the training of those residents, and also to treat patients that were referred to the chiropractic service through the back pain clinic, the chronic pain clinic, from neurologists, from rheumatologists, etc. And also during that time, I completed a master's degree in surgery, and the emphasis there was on orthopedic science. And then I also did a PhD degree in human pathology, and my focus there was on disorders of the spine, and later I subspecialized in ultrastructural changes in articular cartilage that were associated with aging. So I was at the University of Saskatchewan till 2000. After that, I was more focused in, I became more focused in epidemiology and public health, and I left Saskatchewan and moved to the University of Alberta. So that basically was my time in Saskatoon. So I did have about 20 years of at least part-time practice as a chiropractor, but the clinic we were in was very busy, and we saw lots of patients and helped lots of patients.
That's terrific. What an amazing experience that you had, not only working with Dr. Kirkcaldy-Willis, but just that sort of residency program. Do you know if anything like that exists today?
Well, I believe that CMCC still has a residency program, but Saskatoon's not involved in it, and I'm not involved in it, and so I can't really speak to it. But I believe it's still ongoing. But I'm unsure about what their placements are. They're likely mostly in and around the Toronto area, in Ontario, Canada.
Sure. Well, Dr. Cassidy, you've published so many articles in top journals. There's no way we could talk about them all. But I think if we sort of broke things down into clinical themes, some major themes that you've had during your research career seem to be, well, one that received a lot of attention, of course, is cervical spine manipulation and stroke, neck pain, whiplash, and mild traumatic brain injury or concussion. So if we could talk about some of these themes, and I'm sure this is going to help chiropractors and their patients a lot to just hear you speak about each of these themes. So if you could, if we could start with the cervical spine manipulation and stroke theme, and if you could tell us about your experience, your studies that you've done, of course, the one that's received a lot of attention and still does is the 2008 study in spine about risk of vertebrobasilar stroke and chiropractic care. So yeah, if you could give us a background and tell us, what your experience with that is, that would be terrific.
Yeah, gladly, for sure. Just to put some context into this, after I left Saskatchewan, and at the end of my period in Saskatchewan, I had completed my doctoral degree in pathology, but at the same time, I got asked to serve on a Quebec government task force with a epidemiologist who was head of epidemiology at McGill University, Walter Spitzer. And he was in charge of developing guidelines, and he was a very famous epidemiologist who was focused, one of the first persons in Canada anyway, to focus on guidelines. And one of his first guidelines was on whiplash, and you may have heard of it. It was Quebec Task Force on Whiplash-Associated Disorders. And so I joined that task force as a chiropractor, and of course I had a doctoral degree in pathology, but he got me more and more interested in psychosocial determinants of injury, because I was very focused at the time on pathology, what happens to the disc, what happens to the joints, traditional pathological approach to causation. And he opened my eyes to things like psychosocial determinants of disease and recovery, and introduced me to a professor, a Swedish professor who was also on this task force, Åke Nygren. And he was a professor of injury prevention and epidemiology at Karolinska Institute in Stockholm. And I became more and more interested in that. So eventually I went to Stockholm and completed a doctoral degree in epidemiology and injury prevention under Åke Nygren. And so the focus of my career went from a very pathological approach to disease to a more public health epidemiological perspective. And so my career changed course. I was no longer focused on autopsy specimens and looking at pathology in spines, and more focused on psychological determinants and social determinants and risk factors for disorders. And near the end of my time in Saskatoon, there was an inquest called into the death of a young woman who had seen a chiropractor and had suffered a stroke sometime after seeing this chiropractor. And the coroner at the time asked me if I would testify at this inquest because I had a background as a chiropractor, of course, and I also had training as a pathologist, so I understood some of the neuropathology around this issue. And that inquest got me thinking, not just as a pathologist, but also as an epidemiologist. We really don't know much about this disorder, and we don't know really much about the causes of dissection-related stroke, especially in younger people. And that's really how I got interested in that issue. And after my training in epidemiology, I became very focused on more advanced study designs and how could we look at the issue of whether chiropractors are causing strokes in young people or not. And around that time, I got involved in a big project which was part of the Decade of the Bone and Joint, 2010, and a group of us obtained grant money to put together an international group to look at all aspects of the treatment of neck pain, both whiplash and neck pain in the general population. And at that time, I started discussing with experts from around the world that were part of this task force that we should consider doing an epidemiologic study to look at, how common is this disorder? How often are people suffering strokes after seeing chiropractors? Is chiropractic a risk factor for these types of strokes? Questions like that. And over time, I obtained a grant from the Ontario government to do a case control study and a case crossover study to see what the risk was of having one of these strokes after seeing a chiropractor. And so we eventually did a study and published the study, and it was a very large study. We looked at we had 109 million person years of observation over 9 years, and we're able to do this using Ontario health data. As you know, in Canada, we have a national healthcare system, and so we have data. And at the time in Ontario, chiropractors were funded by the government, and we were able to link chiropractic visits to different hospital admissions, including stroke. And so we use that data to complete a case crossover study. And a case crossover study is just a variant of the case control study, but it's a very powerful study design because it's for various reasons. One being that it uses cases as their own controls and therefore has much better control for confounding, because when you're looking at causes of stroke, of course, there are many different risk factors for stroke, and to control for that in a large population-based epidemiologic study is always a challenge. So that's how that study came about. And of course, these studies take years to complete, just because it took quite a while to design the study. It took quite a while to obtain the grant money to do the study, and then to do the study and write it up and publish it. And so we were able to complete that study and look at the risk of vertebral basilar stroke and after chiropractic care, and publish that in 2008.
Terrific. Thank you for going through all that. That's a wonderful background. One of the ways that I really got to, I guess, I've not met you in person, but I've listened to you, and in particular, there was a case, the Connecticut Board of Chiropractic Examiners had a hearing on informed consent. And this was back in 2010. And you were an expert witness in that hearing, and I just remember, listening to the testimony, and I feverishly jotted everything down that I could about what you said, because it really furthered my understanding of the issue. And so I wanted to share just a couple of things that I wrote down and get your thoughts to see if your thoughts have changed at all from what they were. But these are the things that really struck me. And this is in regards to in particular, the 2008 study that you just mentioned. So one of the quotes was, "We do not know that chiropractic care is a cause for VBA stroke, and therefore, if we do not know that, then informed consent is not really informed, because we don't know what the risk is, and we don't know if there is a risk."
Okay. I don't recall exactly what I said at that, but I was actually taken a bit off guard by that whole time in Connecticut. I was asked to come down and talk about my study, and it actually turned into quite a cross-examination that went on for hours, and it was televised.
That was long.
So I was a little taken aback, and of course there were quite a few anti-chiropractic people there and lawyers that were really went after me over this whole thing. And that, I wasn't expecting that. But, that goes with the territory when you do these types of studies. One of the things that epidemiologists focus on is causes of disease. And, causes of stroke, even though we know quite a bit about risk factors for strokes, this particular type of stroke, which has been associated with chiropractic care, is both very rare, and there have been very few good studies on what the risk factors are. Now, traditionally, as you know, strokes occur in older people. And we know quite a bit about that. We know it's mostly due to atherosclerotic disease and hypertension and etc. But when these strokes occur in people under 50 years of age, it's surprising, and especially when they occur in even people that are younger. And there has been quite a few case reports published in the literature about people seeing chiropractors and then having a stroke, or people attending air shows and looking up and having a stroke, or I think I saw a case history of someone who had gone to have their hair cut and had leaned back with their head in the sink and had a stroke. So this idea that rotating the neck can damage the vertebral arteries as they transverse up through the foramina in the cervical spine has really been posited by these case reports linking cervical spine rotation to stroke. The problem with case reports is that there's no control group. So we have no idea if what the person has written, they think, well, the stroke was caused by this or that. They really don't know, because, these strokes may have occurred anyway, and it may just happen to be associated with that, and that's not a cause. It's just something that has piqued people's interest, so they write about it. So you really have to have a control group, because these types of strokes are occurring in the population, and we need to know if they're occurring more in people that have seen chiropractors than they are in just the people that have not seen chiropractors. So we have to have an exposed group and an unexposed group. We can't just take the exposed group and say, okay, that's a cause, because the same disease can be occurring in people that aren't exposed. And that's the whole idea behind doing a case control study on this issue.
Gotcha.
Yeah, so anyway, that was the thinking behind that. And yeah, it was an interesting, it was interesting to go to Connecticut and all these rapid fire questions and being cross-examined by lawyers. But I mean, the bottom line is that when you look at these types of strokes, they're rare. And we do know, for example, that there are some good studies that show that people who have migraine headaches are at greater risk for these types of strokes. But we're unsure, even though there are case reports, whether neck movements are associated with these types of strokes, and specifically whether chiropractic treatment is associated with these types of strokes. So in the case control study, we had two exposure groups. We had people that had seen chiropractors right before the stroke, and we compared that risk to people that had seen their family doctor right before those strokes. And there was really no difference in the risk between the two. And that indicated to us that the more likely explanation is something we in epidemiology call protopathic bias. And what that is people are in the prodrome of having an outcome. In this case, it was in the prodrome of having a stroke. And they're seeking out care for the symptoms that are part of the prodrome. And in this type of stroke, the prodromal symptoms include headache and neck pain. And we know that people with headache and neck pain tend to go and see a chiropractor. They also tend to go and see their family doctor. So we know that the family doctors aren't manipulating these patients' necks. So if we compare the rate of stroke in the people that saw their family doctor versus the people that saw the chiropractors, and we don't see any difference in those exposures, then we can assume that this is protopathic bias acting in this case, and people are actually already in the prodrome of these strokes when they're seeking out chiropractic care.
Terrific. Thanks for going through that. So after all of the work that you've done in this area, what do you think are the next types of studies that need to be done, or do you think we need to do a whole lot of other studies on this question at this point?
Well, it's a difficult issue to study. I think I mentioned we had over 109 million person years of data in the study we published. So you need to use big databases to look at this, which means you're not going to see a randomized trial about this. You may see a cohort study, but if that happens, it's likely going to come from Europe or from other places where there's a lot of health data. And there have been 2 other studies that have used similar methodology to what I used, and they're both American studies, actually. You may be familiar with them. One of them was published by a chap named Thomas Kozloff, and he used US Medicaid data. And another study was published by James Wheaton, also an American, who I believe he used Medicaid B beneficiaries. So there are, of course, databases that you can use to look at that. And those studies more or less had the same result that we had. So there's some consistency there. However, there's another underlying issue that I think is important for people to understand, and that is that healthcare practitioners learn by looking at case reports. So if you think about it, when you did your residency as a chiropractor or a medical doctor, what you mostly do is you follow around a consultant or a teacher in a clinic and look at cases. That's how you learn. So it's not surprising that clinicians like case reports. The problem is that you just can't infer causation from case reports. But of course, you know, if you spend time in a hospital, most of my career I've worked in a hospital, that's what everybody's talking about is cases. And as epidemiologists, we have to remind people, that's fine, learn from the cases, but don't make sweeping statements about causation from cases. Because especially when the outcome is rare, as in this type of stroke, there are other issues at play. There are other risk factors. There are other things you may not be considering. You need a controlled study to do that. And quite frankly, that's been a struggle for me and other epidemiologists who work in hospitals to get those ideas across to all types of clinicians who think differently because they've been taught by looking at cases.
Yeah, and I'll just bring up one last thing about the hearing from Connecticut. Another question from the lawyer was, are medical reports and autopsy reports medical evidence? And your answer was, well, you're using medical evidence and I'm comfortable talking about scientific evidence. And as you mentioned, case reports are not good scientific evidence. So I think that was a terrific answer and again, really furthered my understanding of the issue and the way in which one needs to look at the evidence on its whole. So thanks.
Yeah, I think it's. Yeah, I think I just to jump in again, I think that it's it's important to understand the pathophysiology of disease, and the focus in training clinicians is on that. But it's also very important to understand that what you see pathophysiologically might not be the cause for that disease. And I think back pain, which is something that your audience would relate to, is a good example because when my career was focused in pathology, I was absolutely convinced that the pathology I was seeing at autopsy in the spine was likely the cause for that person's back problems. We now know that people can have disc herniations, facet arthritis, degenerative changes in their spine, and actually not be suffering from back pain. So the link between pathophysiology and causation sometimes isn't as clear or as obvious as one might think. And in fact, even today, I don't think there's any consensus for the majority of back pain problems what the cause is. And that's why you hear the term non-specific back pain and non-specific neck pain. Because if we knew it was due to facet joints, we could call it, facet syndrome or something like that. And I used to be very focused on that, and that's the way I used to think. But now realize that that's not exactly true, because people can have radiologic changes in their spine that are have nothing to do with their symptoms.
Absolutely. What a great point to bring up. And it's something certainly we're seeing repeatedly in the literature these days about those kinds of observations, but I'm not sure how common that is still in practice. I think the mindset still, at least from what I see and hear, is still kind of that pathological model. So hopefully
the information... It's not surprising, because, you just look at the way people are trained. My niece right now is just completing her medical training, and her whole focus has been on pathophysiology, and I've actually been feeding her information about the social determinants of health, and mostly because she doesn't get that training. And during my time working in medical schools, it was a big frustration for me. Students would spend lots of time in anatomy, physiology, all important stuff, of course, but have very cursory understanding of the social determinants, of psychosocial determinants of health, which are extremely important. And this frustration of mine, I think, is shared by a lot of epidemiologists and health policy analysts who realize that medical care is important, but it's not the main determinant of population health. Those determinants have to do with education, income, housing, social capital, things like that. And that's something that, of course, clinicians can't really treat that, so they're not very focused on it. But they have to realize that, and I think intuitively many of them do. If you see someone who's socially disadvantaged, they're likely to have more health problems than someone who's not.
Yeah, absolutely. Absolutely. It's interesting being a clinician. It's interesting being a researcher as well. And to couple the two is very interesting. So now, Dr. Cassidy, can we talk about neck pain and whiplash a little bit? If you could, maybe just like you have for the issue with strokes, if you could just kind of give us some of your insight over the years, maybe how you got started. Well, you already mentioned about the neck pain task force, so maybe start there and then progress to current day, if you could.
Sure. This goes back to the period between 1990 and 95, when I was a member of the Quebec Task Force on Whiplash-Associated Disorders. And it was really the first attempt to summarize the world literature on whiplash and neck pain, and to try and understand what the best treatment was, how common it was, what the causes were, et cetera, et cetera. And of course, I think I mentioned too that was my first exposure to epidemiologists who really were thinking completely differently than I was, because when I joined, I was really firmly in the biomedical, pathological, pathophysiological view of health, which was just a result of my training. And it really opened my eyes discussing whiplash and neck pain with epidemiologists who had a very different view on it. And anyway, we looked at the world literature and came up with some recommendations on how to manage whiplash. And I think I can remember years ago we had a North American and European press conference on this. And the main thing the press focused on at the time after we had published this report in the journal Spine was the fact that we recommended that people not use cervical collars anymore after having a whiplash injury. And I don't know if you're old enough to remember this, but many years ago when someone had a whiplash injury, we would put a soft collar on their neck and immobilize their neck. And I think one of the main findings of the Quebec Task Force was that there was no evidence that that was helping people. In fact, there was no evidence that soft collars even immobilize the spine. And in fact, there was evidence that you were actually changing the person's psychology by reinforcing kind of injury, sickness behavior. Let me elaborate on that a bit. If you're hit from behind and you suffer a whiplash injury in your motor vehicle, and the EMS people come and they put you on a spinal board and they immobilize your neck, and then you go to the ER and you have x-rays and other investigations, and then someone puts a collar around your neck and tells you, you've strained your neck and you need to rest and you need to wear this collar and you need to stay off work. And let's say the second patient goes to a different ER with a different physician who's got more training in the management of whiplash. So that physician, just like the first physician, is going to very carefully examine the cervical spine and rule out any serious disorder, such as fracture or dislocation. But this physician, instead of immobilizing that patient, tells that patient that you've had a strain to your neck. It's going to be sore for a few days. You can wear this collar for a day or two, but you should stop wearing it as soon as possible. You should return to work as soon as possible. You do not have anything super serious wrong with your neck. You will recover quickly. And you should try and get on with your life as quickly as possible. You should take this pain medication over a short period of time. Which patient do you think is going to have a better outcome, given that they both have a common whiplash injury?
For sure, the one that's more mobile, getting back to work quicker, encouraged to get back to life.
And you're exactly right, and the randomized trials now show that. So I mean, it's the same in low back pain. I recall that a trial came out in the New England Journal of Medicine years ago showing that bed rest was a bad thing for back pain. Prior to that, the main treatment for back pain was to tell people to go to bed and take time off work. And we now know that, given that you've ruled out any serious problem, and the majority of back pain and neck pain is not a serious pathological condition. In fact, we call it nonspecific neck and back pain because we've ruled out any serious disease such as cancer or arthritis, inflammatory arthritis, or fracture dislocation. And tell those people to get on with their life, and that's helpful for them. And the ones that aren't able to do that are usually the ones that have difficulty managing the pain, or have been given bad advice, or have had this sort of illness behavior reinforced. So one of the things that came up from the Quebec Task Force was the effect of illness behavior on recovery. And we did a study using Quebec data, which was also published as part of this task force, that showed that insurance factors might be very important in recovery. And it gets to the same theme. If you have an insurance scheme that's rewarding people for having pain and suffering, it's hard for those people to get better, because if if they're going to be paid for the amount of pain and suffering they have, there's no real motivation for them to get better. Because if they're better, they're going to get less. And that sounds awfully cruel, but over and over again now, studies are showing that, especially in the case of whiplash, that if you have a system that promotes payments for pain and suffering and lawsuits around pain and suffering, those people will recover much slower than an insurance system that does not include lawsuits, includes payments for treatment if you need them, but no payment for pain and suffering. And one of the main studies, and probably one of the studies that I'm most proud of, was a study we published in the New England Journal after the Quebec Task Force. I had an opportunity to study everyone who had a traffic injury in the province of Saskatchewan. Again, Canada, we have universal health care, so we have good data and we can follow people who have injuries. And in Saskatchewan in particular, there's government insurance for traffic injuries. Private companies aren't involved. And Saskatchewan government insurance collects through Saskatchewan government insurance, you're able to collect data on all traffic injuries in that province. And so I was able to secure a grant to look at all traffic injuries that occurred over 1 year, over actually 2 years in the province of Saskatchewan, which is a Canadian province in the prairies of about 1 million people. And we followed everyone over a year. And in the middle of that study, the government decided to change and we didn't know about it until just before the study was started. And we had originally had just designed the study to look at prognostic factors, what factors determine who gets better fast and who doesn't. But the government announced just after we had gotten the grant, but before we had started the study, that they were going to change the provincial traffic insurance system from a tort to a no-fault system. And what that meant was there would no longer be any payments for pain and suffering, and that essentially removed all lawsuits for traffic injuries. And they took that money, which was a lot of money, and invested it in rehabilitation centers across the province to manage traffic injuries, not just whiplash, but all traffic injuries. And guess what? What we found was that for the final period during which people were claiming under a tort system, there were lots of these people had legal representation. And they took twice as long to recover as after the change in the system, where there were no lawsuits, but people got, in Canada, free care, for as much care as they needed for their whiplash injury. Those people got better twice as fast. So that's a good example of how social policy can affect recovery. And the mechanisms behind that are complex, but they're not necessarily biological mechanisms. They're psychosocial mechanisms. And to me, that was very, very interesting. And of course, after that study was published, there was lots of controversy because lawyers didn't like it. And I took a lot of flack from lawyers over that study. But I think it's a very important finding, and has huge health policy implications.
Yeah, and wow, what an interesting turn of events. Did you have any idea how that would come out when you heard the news that they were changing?
At first, I didn't really understand the implications. I started to, after I thought about it and talked to other health policy people. And I was a little worried too, because I realized that there was a whole industry of injury lawyers in Saskatchewan at the time, representing a lot of injured people. And of course, you have to think about the other side. These injured people have been injured and they need some compensation. But is it wise to pay them for how much they're suffering? Especially, now I'm not talking about really serious injuries, because that's a little different, such as catastrophic injuries fall under a different set of rules. And in fact, prior to the change from tort to no fault, one of the motivations for the insurance company, now this is a Crown government corporation, not a private insurance company, but they could see that the treatment of people with severe brain injuries was very unfair. And the reason for that was because under a tort system, they only had so many dollars for treatment for their brain injuries, and then they had to sue for the rest. And that was very unfair, because you take someone that's had a serious brain injury, and suddenly they have to get a lawyer, they have to have a court case to determine how much money they're going to get on with their life. And of course, that takes many years. It's much better if those people forget about the court case, give them everything that they need, give them all the treatment they need, help them fixing up their house or whatever else they need. That's way cheaper than having all these lawsuits. And it's way fairer, because those people can get on with their life much quicker. And that was one of the main motivations behind changing this system. The government in Saskatchewan, they weren't out to make money off traffic injuries. They were out to serve the population. And I think that health policy change was great. I think, as an interesting sidebar, of course, there were many lawyers that didn't like this, and many lawyers are politicians. And eventually there was enough pressure to force the government to make a policy change years later, even though the no-fault system was working quite well. So that under pressure, they decided to allow people to have the choice. So if they wanted to, they could choose to claim under a tort system where they could sue for pain and suffering, just like the old system. Or they could choose to be part of a no-fault system where they had, I think it's up to over $2 million in treatment benefits, or even more. I'm not sure now, because I haven't been in Saskatchewan for years. And guess what? The majority of the population stayed in the no-fault system. I think a few moved over to the tort system, but very few.
Wow, that's really interesting. And you had mentioned during that discussion about brain injury, and I think that's a perfect segue into our next topic area, which you've done a lot of work in, and that is mild traumatic brain injury, or concussion, and you've done some work on sport-related concussions as well. Can you tell us what you've done in this field?
Yeah, well, to put it in context, after I trained as an epidemiologist and had I was doing that training through Karolinska Institute in Stockholm, Sweden, and I had the opportunity to get involved in a WHO initiative through Karolinska Institute, and the head of neurosurgery there and my supervisor, who was head of injury prevention, epidemiology, and injury prevention and epidemiology, they received the designation as a WHO collaborating center. So Karolinska, which is a very prestigious medical university in Europe, it's the home of the Nobel Prize in Medicine and Physiology. They set up a WHO collaborating center that with a focus on neurotrauma. And as part of that, there was a coalition of agencies that wanted to get involved in looking at the incidence, the recovery, the treatment, risk factors for mild traumatic brain injury. And for your listeners that probably most of them know this, but brain injury is classified as mild, moderate, and severe. The majority are mild traumatic brain injuries. These are classified as Glasgow Coma Scale less than 13 to 15, 15 being no loss of, or less than 30 minutes loss of consciousness after the injury, and less than 24 hours of post-traumatic amnesia. And about 80% of brain injuries are mild traumatic brain injuries, so they're very common. And sports concussion would be part of that, but most people who have a sports concussion don't lose consciousness, so it would be a very mild traumatic brain injury. But originally my focus was more on mild traumatic brain injury with more of a focus on traffic injuries. In other words, mild traumatic brain injury occurring after traffic injuries. And we know that falls and traffic injuries are the main cause for mild traumatic brain injury, for brain injury in general, actually. And so we got this big coalition of experts from around the world together to do a very long look at, and very in-depth look at mild traumatic brain injury. It involved experts from around the world. And the work was done out at Karolinska Institute in Stockholm. And at the end of that, we published a supplement in the Journal of Rehabilitation Medicine, summarizing our findings on diagnosis, treatment, risk, et cetera, et cetera. So that's how I got into mild traumatic brain injury. And after that, I moved more and more into MTBI, or mild traumatic brain injury, and more away from musculoskeletal. However, it's interesting because there's a lot of overlap between whiplash and mild traumatic brain injury. A lot of the symptoms are similar, and we can get into that. So, over the last few decades, I've been focused in that area and publishing in that area. And I was contacted several years ago to join a group of sports physicians and scientists who have every so many years published guidelines on the treatment of sports concussion. And I think they invited me because I had expertise in doing systematic reviews and assessing issues around causation, which are big in the area of sports concussion right now. And so I was invited to be a part of a consensus group that does a systematic review and publishes guidelines for physicians around the management of sports concussion. And we met in Berlin several years ago, and ended up publishing our results and our guideline in the British Journal of Sports Medicine. I think that those articles were published back in March of 2017. So that's my long preamble of how I got involved in that.
One of the things... Oh, go ahead.
No, you go ahead.
I was just going to say, one of the things that I think of when you're talking about mild traumatic brain injury, it seems similar almost to what you're talking about with neck pain. Looking at the literature now, babying the neck or, getting extended rest breaks seem to be the similar kind of recommendation for mild traumatic brain injury. And now it seems that, the recommendations may be, again, maybe a couple of days, but then soon after, let's get back to work, let's get back to school. If you're a child who just had a sport injury, is that what you see also? Is that what the current recommendations are?
Yes, almost to the point where I was involved with a group of French epidemiologists at the University of Bordeaux, and just because I moved back to North America at the time, I was living and working at the University of Southern Denmark. And I got involved with a group of epidemiologists in Bordeaux who were focused on injury epidemiology. And we would have yearly meetings and discuss and think about different issues around injury. And it got to the point where we started to realize that, you have a physical injury in a traffic collision, let's say, or any type, or a fall or something like that. Sure, you have the physical injury is important, and it's going to determine the acute treatment and the acute outcomes. But there are many commonalities about, especially people who have persistent symptoms. Many of the symptoms are similar. Doesn't matter what the initial injury was, and many of the determinants of recovery in people that are beyond, who haven't recovered during the acute or subacute period, many of those determinants are very similar. And a very good example of that is how people cope with their, not just their injury, but also how people cope with their chronic disease, for example. If people have good coping skills, and by that I mean they're not focused all the time on their disability, they're able to focus more on what they can do. They're able to sort of readjust how they think. They might end up with some disability, but they kind of are able to redefine themselves. Okay, I have this disability, but I'm still able to function. They have a much happier life, and their symptoms improve more and faster than those people that are focused on their disability, won't have withdrawn from society, do not return to work. And that's another whole issue, because workplaces need to accommodate people with disability. And if they do, these people are much happier. They have better health-related quality of life. And it really gets back to this point that physical injury, of course, the acute care is very important. If you have a physical injury and you go to the hospital, the doctors need to focus on your acute injury and get that under control and treat it properly. But our healthcare system, in a way, fails people when they start to develop chronic problems. And the problem is, after they've developed those chronic problems, it's very hard to get them back on the right trajectory. And so I've been involved in a number of studies where we've looked at and measured how people cope and measured their coping behavior before they become chronic. In other words, they have an acute injury, and we measure some of their behavioral traits, how they view how to cope with injuries. And the people that have a very active view on how to cope with things, in other words, they're not passively trying to cope with everything. They're not thinking, oh, I'm a victim. Oh, my doctor needs to help me. Oh, there's not much I can do to help myself. I shouldn't be very active. If you compare those people with the same injury to people that think, okay, I've got to make a big effort to help myself. I'm going to get back to work. I'm going to get better. I'm not going to focus on my injury all the time. I'm not going to focus on my pain all the time. They just have better coping mechanisms. And the reasons for that are very complex and not completely understood. But those people, they get better way faster than people who have what we call maladaptive coping. And that's pretty much across all injuries. And I've personally published studies on whiplash and brain injury and back pain. And we always see the same thing, that coping behavior is a big determinant of recovery.
Yeah, so important, so important. Do you have any tips for us clinicians on how to help people with that?
Well, I think it's not my tip in particular, but I think most of the guidelines, especially around conditions that chiropractors might treat, like back pain and neck pain, their focus, of course, is to make sure that you don't contribute to the illness behavior of your patient. Okay, so how would you do that? How might a clinician end up doing that? Well, they might do that by over-treating the patient. They might do that by applying passive treatments to the patient and not trying to mobilize the patient and get the patient more active. And they might do that by saying, okay, I'm going to look after you, don't worry about things, I'll take care of everything. Whereas another clinician might say, okay, well, we'll tackle this together. I need you to really make an effort to do exercises, to re-engage in your previous life, to try and get back to work. And it's important for workplaces to accommodate injured workers. And even if they can only go in for a few hours a day or a few hours a week to return to some form of injury. And during the time I was a professor at the University of Toronto and working at the Toronto Western Hospital, I ran a center that was focused on return to work and recovery after workplace injuries. And the main thing that we learned there was that industries that have very well developed vocational rehabilitation programs where they welcome injured workers back and accommodate them and offer them part-time return to work and escalating return to work, where they start very slowly for only a few hours and increase over time. Those people actually do way better than the person who's fighting with their supervisor and won't return to work, or a workplace that won't offer them accommodated work. That offer of workplace accommodation is actually more powerful than whether they have physiotherapy or chiropractic or medical care. So again, getting back to this theme of sort of what I've done in my life, I started as a clinician, and of course clinical care is very important, but we cannot ignore the psychosocial determinants of recovery. We cannot ignore people's coping behavior. We cannot ignore that they might be depressed, because people that are depressed aren't going to get better. We cannot ignore that they don't have a cooperative workplace that's not offering proper workplace accommodation. We cannot ignore that this person hates their job because their supervisors, they're in conflict with their supervisor all the time for various reasons. All those issues contribute greatly to how people recover from workplace injuries, for example. And it's the same thing with other types of injuries. And getting back to the Bordeaux group, I no longer participate in that group, but I know that they're very, very focused on what are the common symptoms and the common issues across injuries, and should we maybe help clinicians rethink this? Don't label people as a brain injury, because they may have a mild traumatic brain injury acutely, but they're not going back to work because they have ongoing neck pain or headaches or whatever. And chiropractors could contribute in this. For example, in mild traumatic brain injury, one of the most common symptoms 6 months out is neck pain and headache. And, chiropractors are involved in treating that. So these people will go and see chiropractors. And as a chiropractor, you want to make sure you're aware of that person's social situation, as part of the problem that their workplace isn't accommodating them. You have to be aware of their family situation. Is their family supportive of them, or is their family contributing to their, illness behavior by doing everything for them and telling them, you need to rest all the time? So all these, healthcare is very complex, and especially when you get out beyond the acute period.
Well, what a fantastic summary. My mind is expanded greatly, and I'm sure it will take me some time to process all of those details. I'd like to end today with one thing that I ask all of my guests, which is to provide any advice or motivation to assist practitioners or students alike to pursue research careers in chiropractic science. So if you could offer anything to those who might be thinking about a career in chiropractic science or perhaps just science in general, that would be terrific.
Yeah, I'd like to, and of course this is my own personal bias, but I think, there's a good argument for this, that having worked in Europe and having worked in North America, in Canada, I haven't worked in the US, but I suspect Canada and the US are similar. In North America, there's a big focus on basic science research. And in Northern Europe or in Scandinavia, where I've worked, in Denmark and Sweden, there's a much bigger focus on clinical research. That includes psychosocial determinants of health. And I would like to encourage chiropractors to look at careers in clinical research and not focus so much on basic science, because I think the answers to a lot of the issues that chiropractors are involved in, the conditions that they're involved in treating, the determinants, basic science isn't going to solve it. What's going to solve it is more research into clinical care, long-term clinical care that includes looking at psychosocial issues. And, for example, even in my own career years ago, I saw this. At the end, I started out as a chiropractor thinking very traditionally, thinking in terms of pathology and, what happens when I manipulate a spine, am I affecting the disc and the facet joints, etc. In the end, my last year of clinical practice, I was working at a student health center at the university. And as part of a multidisciplinary group that included myself, the chiropractor, a family doctor, a pain psychologist, and a social worker. And if a student came into that center with acute back pain, often it was a GP and myself as a chiropractor that were involved in that care. If a student came in and they were having recurrent musculoskeletal problems or recurrent headaches or back pain, neck pain, things like that, and we already knew that they were healthy, the focus was more on their psychology. So, they might receive care from the GP. Well, they'd be seen by the GP. They might see a specialist to rule out something. But they were spending more time and they might see the chiropractor, who at the time would try and help them get over their acute symptoms. But to really help that person in the long term, there was more emphasis on their social situation and on their managing their chronic pain and giving them tools to deal with that. And for example, cognitive behavioral therapy is now being applied across lots of injuries, and the results are promising. It's not the only answer, but nowadays health conditions, we understand them as being more complex. So I think the future for chiropractors is to be integrated more into the system. And of course, in Denmark, I saw that because chiropractors are trained at a medical school. In North America, chiropractors are trained outside of the medical system, and they're not integrated into that system. And now some have done that through their own efforts after they graduate to work in clinics with clinical health psychologists and others. But I think the future, not just for chiropractors, but for family doctors even, is to work in health centers that offer more wide-ranging care for their health conditions. Because, one of the big problems we face in society right now are chronic diseases. And those chronic diseases, they have lots of implications beyond just medical care. They have social implications, they have psychological implications. And unless you're dealing with that person holistically, I don't think they're getting the best care. So just to get back to your question, I'd like to encourage chiropractors, if they're interested, if they're foolish enough to go into research, to consider a career, outside of the traditional basic science approaches of bubbly test tube stuff, and to maybe focus more on clinical issues and psychosocial issues. The problem with that is that our payment systems, of course, are focused on acute care, and but I still think that if chiropractors were to spend more time doing that, you'd see better integration into the system. And I saw that firsthand in Denmark, where there's way more focus on clinical studies and prognostic studies, looking at what are the main factors that are stopping people from getting back to work, and how can we as a chiropractor contribute to that as part of a multidisciplinary team.
Yeah. Wow, such great advice. And I must say, this interview has been such a treat for me. As I said, I really wanted to have you on the podcast for a long time, and I especially enjoy just listening to you speak about the things that you love to do. It's always a pleasure to hear what other chiropractic researchers and researchers in general have been up to. But your career is such a fantastic career. So thanks for doing what you've done for all of these years and contributing to our profession and the health professions in general. So thank you for that, and thanks for coming on.
Well, thank you very much for having me.
Thanks for listening to this interview with Dr. J. David Cassidy. I know I certainly learned a lot during this talk, and I hope you did as well. Stay tuned for more great interviews coming up. Also, if you didn't know, we are now on YouTube, so check out our YouTube channel, Chiropractic Science. Bye for now.